Innovation, imagination, wonder. These are just some of the words used to describe Dr. Harvey Passes. Dr. Passes explores interesting people and ideas that will stimulate you. He questions the people who develop, create, and employ novel concepts in business and everyday lives. He especially loves to speak with successful people. How did they do it? How can you do it too? So let's join Dr. Harvey Passes in his quest of wonder and curiosity as we watch Dr. Harvey Passes Presents.
Once in a while, you reflect on something that was very interesting, very informative, and, well, it really did something to really help you in your life. And I did that with one of my shows. I reflected upon an individual who came down here and explained an area of medicine that most of you are really in the dark about. And today, we're going to get a little bit of light shined on this subject. And I asked Dr. Rory Briedart, a physician who specializes in endocrinology and diabetes. And it's all about diabetes. So if you know anyone who is diabetic, or you're afraid they're going to become diabetic, or for yourself, you want to learn more about this terrible illness, you better listen, get some paper, pencil, or pen, and write down notes because you're going to learn a lot today from an eminent expert in the field. You like that?
Yes.
Everybody say that?
Thank you very much.
Dr. Rory Briedart.
Thank you.
Thanks very much. Let me just tell the folks at home a little bit about you so they understand your illustrious background. You went to Emory University for your undergraduate education. Then you went to the renowned medical education. You got your medical education at the Sackler School of Medicine in Tel Aviv, Israel.
Yes.
Then you did your residency. Then you came back here to the States to Long Island Jewish Medical Center. Then you saw the light, and you knew where you wanted to go, and you got your fellowship in endocrinology at Mount Sinai Medical Center. It's just like, this is your life.
That's right.
Then you went on, became a clinical instructor in medicine at NYU School of Medicine, where I got my dental degree at NYU. And now you're an attending physician at North Shore Manhasset, Long Island Jewish Medical Center, and at St. Francis Hospital right down the road here in Roslyn. And you're also the medical director of the Outpatient Diabetes Care Center at St. Francis Hospital. And also in your free time, you got a private practice in Great Neck.
Yes.
Okay? I don't even know if you're like me if you have free time. You're a busy guy. Busy guy. But I'm thrilled that you took the time to come back so we could talk some more all about diabetes and we can explain it again because I think that the information you have is just invaluable. So thanks very much, Dr. Briedart, for coming back here for us. Let's begin on a broad general term and a broad general understanding. What is diabetes?
Diabetes is simply high blood sugar. So diabetes is really the problem that someone goes to the doctor, has a blood test, and the doctor tells them, we found your blood sugar high, you have diabetes. That's simply what it is.
Right, okay. So now you've got high blood sugar. Big deal. What is high blood sugar going to do to you in a broad general term? I mean, everybody always says, sugar's good for you, have sugar. Others say, sugar's terrible for you, it'll make you fat. But you're talking about sugar in the blood affecting you and influencing diabetes. Is there a mechanism here? What does sugar do?
Well, blood sugar does damage if it's in high amounts. So if you have too much blood sugar, the blood sugar level in your body is too high, then that does damage, and we can talk more about the
different
the
types,
complications of diabetes, hopefully later on.
Okay.
But just to get back to what you said before, sugar is good, and we all need sugar. It's only when the body has a problem processing that sugar that we develop diabetes. So either we don't make enough insulin, the hormone, the protein that the pancreas makes for us to use sugar properly, or we make enough insulin, we just can't use it the right way.
Okay, so basically it's a condition where insulin, which we had mentioned previously, acts as a key to open up the door to the cell, and sugar's got to get into the cell to give it energy.
That's correct.
And to make the cell work.
Right.
It's as Wheaties, it gives it its energy. And either there's a defect in the insulin not letting the sugar get in, or maybe there's another kind of problem that comes about, whereas insulin isn't working in the proper way, so the sugar should get into the cell to work right. Is that generally?
That's it, or there's just not enough insulin.
not
Correct.
enough insulin. Okay, tell us, there's a type 1 diabetes or diabetic, and there's type 2. What is type 1?
Type 1 is the case where you just don't make enough insulin. So type 1 diabetics actually aren't making any insulin at all.
Oh.
We don't understand why, but in some patients, the type 1 diabetic patients, their immune system attacks their pancreas. It attacks the insulin-producing parts of the pancreas.
Right.
And for that reason, those patients cannot make insulin. They are what we call insulin-dependent or juvenile diabetics, and we have to give them insulin to treat them.
I see.
As opposed to the type 2 diabetic.
Well, hold on, before we go to type 2, so in type 1, since you don't have, and correct me if I'm wrong, since if you don't have enough insulin, or any insulin, and you take sugar in, your cells can't get the sugar to use it properly.
That's correct. All the sugar you take in would just build up in the blood to very, very high levels because you cannot get any of the sugar into the cells.
And that in itself would cause you a problem by
That's
being
correct.
overloaded with sugar floating in your bloodstream.
Right.
Okay, so the insulin is not there to let it get into the cell so that the cell could get its energy.
Correct.
Okay, type 2 is what?
Type 2 is the patient that is able to make insulin but either cannot make enough insulin or makes an adequate amount of insulin, but that insulin can't be used properly.
So is there a problem in the quality of the insulin?
In some cases, they can either make insulin that's of poor quality, or they just cannot make enough insulin for their needs.
And that's a type 2.
Correct.
So type 2 has insulin being made, whether it's or just an inadequate supply or a poor quality of it.
That's right.
Okay, and they're treated, both these type 1, and don't get into it this moment, but type 1 and type 2 are treated differently?
A little bit. The type 1 diabetic is always treated with insulin.
Right.
The type 2 diabetic can be treated with insulin, but can be treated also with diet and exercise, pills, or insulin.
Okay, we're going to get into all that in specifics in a few moments. What is, I've heard this many times, and explain it to me, what is pre-diabetes?
Pre-diabetes is a condition that one has before they develop diabetes. So we have very strict criteria in which we diagnose diabetes, high blood sugar. You have a blood test. If your blood sugar is above a certain amount, we say you have diabetes. If you have a slightly high blood sugar, not normal, but not enough to call you diabetic, then you fall into this pre-diabetes category. And the reason that we have this category is to be able to advise patients to watch their diets, eat right, lose weight, exercise, so that we can avoid them becoming diabetics.
I see. Very, very interesting. So this would be picked up in a routine blood test?
Correct. Correct.
Is there some way in which an individual at home watching right now could say, without a blood test, gee, I think I'm pre-diabetic? Is there something an individual would know, or it's so silent that you wouldn't know it?
Well, they may have some of the symptoms that a diabetic has. So
Could you give me what those symptoms are?
Yeah, they may have blurry vision, they may have excessive thirst, excessive urination, or unexplained weight loss. Those are really the 4 symptoms that patients have. So if anyone's experiencing any of those symptoms, those are things that they ought to come to the doctor and get a blood test and see if their blood sugar might be high.
Interesting. Okay. How are you going to diagnose, other than a blood test? There's a basic blood test that you take for diabetes. And if you suspect on a blood test that someone is diabetic, is there another test that you do, more involved?
Well, yes. There are several blood tests. The first one is what we call a random blood test. In other words, you just come into the doctor's office. You may have eaten, you may not have eaten. It doesn't really matter. It doesn't matter what you ate. We do a blood test. If the blood sugar is very, very high, over 200 on that blood test, then we can say that someone has diabetes. The other blood test that we can do is a fasting blood test. So patients come in after an overnight fast, and there we have a little bit of a different level. And there, if the blood sugar is over 125, then we can say that person has diabetes. So we either have the random, where you walk into the doctor's office, no preparation, just get a blood test, and it just shows a very high blood sugar level, or you come in fasting, and it's high.
So fasting at 125, you consider diabetic?
Over 126,
Over 126 and
right.
above. So fasting. And what is there any value in the glucose tolerance test?
Right, that's the final test. We often do that test in the patient who has pre-diabetes, for example. In other words, their blood sugar is slightly high. We do the glucose tolerance test. That's where the patients have a fasting blood test. We then give them a certain amount of glucose to drink, and then 2 hours later do another blood test and see how they handle that sugar. And based on the results of those tests, we can see whether or not the patient is either normal, has pre-diabetes, or has diabetes.
What does having high blood sugar do to you?
Well, that's the problem. The high blood sugar is what does all the damage, and the damage is really done in areas, 4 areas: the eyes, the kidneys, the nerves, and the heart.
Wow.
So those are
4
really
biggies.
Yes, those are the big 4 problems. So when we talk about one of the symptoms being blurry vision, for example, one of the things that having high blood sugar can do is damage the back of the eye, the retina, and that's this term retinopathy, which some people may have heard of.
Yes, sure.
Having high blood sugar can affect the nerves, and when you affect the nerves, you get a term that people may have heard of called neuropathy, and that sometimes manifests as pain or tingling in the feet, or sometimes it's manifest as no feeling at all. These are patients that step on something at home, don't even know that they stepped on it, and then come to the doctor a few days later with a problem, and they say, I can't believe I have a problem like this. I don't feel anything.
Wow. What about the fingertips?
The fingertips are also involved. Usually it's the legs first, but the fingers are second, involved in nerve problems. So it's what we call a stocking glove kind of distribution of the problem, which is what leads us to think sometimes when patients come to the office that this may be a diabetic-related problem as opposed to some other problem.
So it's just fascinating. Why now, as a dentist, I come across this all the time when a patient's diabetic, and especially if we're going to provide them with implants. Excuse me. One of the questions that we ask, are you diabetic? And if they say, yes, I am, there's a major concern about the diabetic's ability to heal properly. Is that true?
Yes.
And could you explain why is that true?
It's because diabetes affects the blood vessels, which is why some of the eye problems develop, which is why some of the nerve problems develop. Really, the mechanism comes down to the blood supply to those areas. The eye and the nerve have very, very small blood vessels which supply them, and those blood vessels are very vulnerable to damage from high blood sugar. So healing is a problem with diabetics. So when someone's going to have a surgical procedure, especially a dental implant, they must be under good control prior to placing the implant, because everyone wants a successful outcome from the implant. So it's very good that you asked that, and we're certainly happy in the diabetic field that people aren't having implants placed when they're not well controlled.
Right. What happens if you place the implant and the individual is a diabetic, and the patient says, I want the implant no matter what, and I understand the consequences. I send them to you, and you take care of them, keep them controlled, and they're compliant. And the implant, everything works properly. It integrates with the bone, and that's the end of it. And then 6 months to a year later, they all of a sudden go off the wagon, and their blood sugar starts rising. Is there a potential that implant, I don't know if you can answer this question, but could the implant all of a sudden begin to fail?
I think that's always a possibility. I think that obviously the better you control your blood sugar, the less likely you are to have complications. I think that someone who goes through the time and the effort and the expense of dental implants ought to have their blood sugar well controlled, because I think, and hopefully we'll get to talk about that, it's not very hard to do, and I think that the potential payoff is huge.
That's correct. That's correct. Is diabetes a disease that you catch? How does one get diabetes? Do you catch it from someone who has it, or do you pick it up one day and explain?
Well, for most of our patients, diabetes is a result of being overweight.
Overweight.
So most of our patients don't really catch diabetes. It's not an infection, but really it's just a manifestation of being overweight. So the pancreas, these are obviously type 2 diabetics, can make insulin, but just not enough. For our type 1 patients, our juvenile patients, or our thin type 2 diabetic patients, we often don't know where it comes from, how they got it. We know that there are certain genetic factors. In other words, it runs in families. We can do DNA testing and see that people have certain genes that lead them to develop diabetes, but most of the time we don't know where it came from in those patients.
So we really don't know. So in essence, you can't inoculate yourself against, prevent it, except lifestyle.
Correct, but that accounts for a lot, because most of our patients really fall into that category. It's very few thin type 2 diabetic patients that we have, and 90% of our diabetic patients are type 2. So
all lifestyle. It's amazing.
Right.
You know, I was reading something, and you're the person to ask about this. I was reading something the other day that there are a number of researchers out there who are gaining this growing opinion that Alzheimer's is really basically a diabetic condition. It's a form of diabetes. Have you heard this? Have you read this?
I haven't heard it, but it would make sense. I think that, again, small blood vessel changes that lead to problems may cause problems in the brain, which would lead to the manifestations of Alzheimer's. I'm not a neurologist, so I couldn't comment specifically, but it would make sense to me that they would have similar mechanisms. Does
eating sugar cause diabetes? I remember as a kid, stop eating so much sugar, you're going to get diabetes, my mother would say to me. You know, what did I know? I said, okay, Mom, I won't eat the sugar, you know. So, I mean, explain that. Is that a fallacy or not?
We believe it is. That
it's a fallacy.
Yes, that it is a fallacy, that eating sugar does not cause diabetes. Obviously, again, it becomes a calorie problem, so that people who eat a lot of sugar usually become overweight, and that leads them to develop diabetes. But in general, we believe that eating sugar does not cause diabetes. The important thing is, like you said, to lifestyle, stay thin, exercise, eat right.
So I just want to put this to rest. Type 2 diabetics will usually be overweight people, and we still do not know why, when you're overweight, diabetes will come on. Is that correct?
That's correct. We think that those patients don't make enough insulin.
Right.
We can measure their insulin levels. Right. We don't know why their pancreas can't keep up the way another overweight person's pancreas can. That's correct.
Okay. Then we'll put that to rest. Now, I've heard of the hemoglobin A1C test. Now, somebody listening goes, what? What is he talking about? Explain that.
The hemoglobin A1C test is a test that's a very useful blood test that we do in the office. Mm-hmm. This test can tell us how someone's blood sugar has been over the last 3 months. Mm-hmm. So.
Oh, really? Gives you a historical.
Right. Okay. One blood test can tell us this. The way it works is that hemoglobin, something everyone's heard of, it's a component of our blood. Hemoglobin has a property that allows sugar to stick to it. And that's normal. So a normal patient, someone who does not have diabetes, certainly has sugar in their blood, and that sugar sticks to their blood, and we know what a normal amount of that is. If someone has diabetes, more sugar is in the blood, more sugar sticks to their hemoglobin, so they have a higher level of sugar stuck to that hemoglobin. They have a higher hemoglobin A1C.
Isn't that interesting?
So we can look at that and say, you have more than you should, so it's very likely you have diabetes, but also it allows us to look at the value of our treatment. In other words, when someone starts out and they have a high level of hemoglobin A1C, we start a particular treatment, we check them 3 months later, and we say, wow, your hemoglobin A1C really came down. We can see that our treatment has really helped. Whereas if nothing's happened, or even worse, if the hemoglobin A1C went up, we know that, yes, that our treatment is not working, and we have to shift gears and go into something else.
That's fascinating. So it's like a marker.
Yes.
Oh, that's fascinating. It's very interesting. Let's get down to treatment. So an individual, let's take the simple one for, like, I don't know if it's simple, but type 1 diabetic. Someone comes in and you find out the individual does not produce any insulin at all. What should that individual do?
That patient, you're right, it is very simple. That patient has to go on insulin. So the type 1 diabetic, we start on insulin in the office right away.
And how do you give them the insulin? Do they take it as a pill? Do they take it as an injection? They stick it up their nose, their ear, their eye. How do they get the insulin into themselves?
Insulin now is only by injection.
Injection.
So the type 1 diabetic is treated with insulin injections, and we can talk a little bit more about hopefully the insulin pump and things like that, but insulin is now given by injection. It's a lot better than it used to be. The old image of the vial and the syringe and having to carry these things with them, and cold packs and refrigerated are all out now. Insulin pens make this much easier.
You have one here?
Yes, we have. We actually have an insulin pen.
Hold it so see if we can get a close-up from my cameraman here on.
This is just one kind of insulin pen.
Now we can open this.
Yeah, we can just pull that out.
Okay, let me just.
Don't knock the water over.
Okay, right, don't knock the water over. Okay, here, and I'm going to open this pen up, and we'll get a close-up here. Here we go. So now we have a vial in here. Is that correct?
Right, and that comes preloaded, so there's no cartridges anymore. Nothing even.
Do I pull this out and turn it upside down?
That's all done. The needle is here.
Oh, so.
And what you can do is, I'll let you do it. Actually, you can just peel that top off.
Let's see if we got it. Okay. Oh, I see. Okay, so let's get a shot of this first. Right over here, so we see what it looks like. Okay. Now I'm going to peel
the cover off.
Peel the cover off here, as so. And this is what an individual will do at home.
Right. And then that just screws that right. Just screw that right on.
Oh, very simple.
Okay, till it's snug. Then you can just pull the cover off.
This area here.
No, that plastic cover.
Right.
Okay, and now that little pink cover covers the needle.
Right, and that gets pulled off too?
Correct.
Okay.
And you can see
very
right.
It's almost like a tuberculin syringe.
It's
very tight.
31 gauge needle. I know something you're very familiar
yes.
with. Okay, and that's a 5 millimeter needle, so
right.
very, very small. And then at the other side, the patient can simply dial the dose of their insulin.
Oh, how clever. Look at that. Let me see if we can get a close-up of this. So you can see here, there's like a little window. Oh, the cameraman's doing a good job. See that? So you just turn that.
The other way, that's it, yep.
And you just dial your dose.
And then just insert the needle and push the button.
Insert the needle as such,
and then
and
just
push your thumb down.
And you'll deliver the insulin.
And that's it. And
right.
just give it in a muscle.
Actually, it's under the skin.
Subcutaneous.
So it's a subcutaneous injection. Usually we recommend in the abdomen because the absorption is the most consistent there.
Oh, that's it.
And that's it then.
And the individual would have to do this on a period, like once a day, twice a day, whatever is necessary.
Whatever is necessary. In general, for the it won't fit with the cover.
Right, I realize
that's okay.
Yeah,
the type 1 diabetic will probably be doing this 3 or 4 times a day now.
Wow.
Yeah, before meals and at bedtime.
Right.
So 2 different insulins, an insulin that we take before meals and at bedtime. The beauty of that is that the diabetic has their lifestyle freed up a lot more than they used to. In other words, now, if a diabetic wants to sleep late, for example, they don't have to worry that the insulin they take is going to peak at a certain time and they must eat at a certain time.
Right,
If they're at work late or they have to skip a meal, it's really okay because the short-acting insulins work at the time of their meal and then they're out of the system, so the patients can really live much better life. Used to be patients had to eat at a certain time. It was terrible.
Right.
They don't have those restrictions anymore.
That's excellent.
They also don't have to refrigerate the pens, so that's very nice. They can stay out of the refrigerator at room temperature for 28 days, so this can stay in your pocket and you can just go with it. It's a lot better.
Wow. Okay, so that is terrific. Let's get back to new things that were created. You had told me that there was an insulin administration through inhalation.
Right.
And basically you snort this, so breathe it in. What happened?
Yeah, it was very unfortunate. It was inhaled insulin, the insulin that you took in by mouth, very much in the way that an asthmatic took in an inhaler.
Right.
The problem was that the company that made it did not feel that it was selling well enough and decided voluntarily to withdraw it from the market. So yes, a lot of us in the diabetic community were very disappointed.
That's crazy.
Yeah, a lot of patients loved it. Rather than take a shot, they could just use inhaled insulin. But it was a financial decision, not a efficacy decision.
Not a medical efficacy.
Correct. Right. There were no problems with the product. It was just dollars and cents.
So there's a market out there, and they just don't. That's crazy. That is crazy. I know there are so many people who would probably disagree with that. That is absolutely crazy. Okay, talk about treatment of type 2.
So treatment of type 2 can involve insulin, as we discussed, but
remember, this is the individual who can make insulin, but not enough or of poor quality.
Correct.
Okay, how do you treat that?
So the first thing we do is we give all of our patients education in lifestyle. So we talk to them about exercise and we talk to them about their diet. Exercise is really any kind of exercise you can do. We always say is good.
How about with a knife and fork?
That is not good exercise. We like the aerobic exercise certainly, and I always like to explain to patients that this does not involve a big investment in equipment. Right, exactly. You can just a good pair of sneakers, a t-shirt and shorts or sweatpants, and just go out and walk. And we love to see patients walking about a half hour a day, every day, or more if they can do that. Anything else that patients want to do, if they want to work in the weight room or something else, that's fine too. But really, it's the sustained aerobic exercise, that half hour a day, each day of walking, that we encourage. And this should only be done, I just like to say that everyone should just check with their doctor first before they begin an exercise program. But yes, that's really that's the exercise. So yes, it's very easy. It doesn't involve any lessons. You don't need anyone to show you how to do this.
Just walk.
Just walk.
And if it rains or snows or rains, just go to the mall. Walk to the mall and leave your checkbook at home so you don't buy anything. Just walk. It's important to check your blood. Is that correct?
Yes.
On a daily basis, weekly, monthly, yearly?
Yeah, daily.
Daily basis. How does one do that? We have equipment, I see.
Yes, we have glucose meters, and the meters are very simple to use. And what patients can do is they can actually insert a strip into the meter, or in this case, the meter can actually come with the strips preloaded.
Right.
And the patients prick their finger.
Let me just see which one. So this is the meter. Let me see if my cameraman can get a shot of this.
That's one of the meters, yes. I don't have a strip there, but...
Okay, so this is one, and this is the other. And this one...
That's upside down.
I'm sorry.
There you go.
Okay, hello? Okay, wait, let me see. Okay, it look like cell phones. Okay, so this one here has got its own meter, its own strip built into it. Is that correct?
This has the strip built into it.
Right.
This has the one that you have to insert the strip.
Okay, so now what do? You prick yourself?
You insert the strip, you prick yourself, you put the drop of blood on the strip, and in 5 seconds, you'll get a reading of
That's fantastic.
your sugar.
That's fantastic. Thank you. That's fantastic. That's great. So you'll always be on top of what your blood sugar is. And if you see your numbers are like 126 or higher, that's when they give you a call.
Right. Or we have the patients write it down. They keep a diary. They bring it into the office. We can then decide if we need to make a medication adjustment. What the beauty of the new meters now is that we can actually download the contents of the meters onto the computer when the patients come in, and we can print out the entire diary and show them charts of when they're high, when they're low, when they're normal.
It's fantastic.
Right. So we can really make a lot of treatment decisions and keep the blood sugars under much better control than we could before.
We're almost out of time. Briefly, talk about what is the insulin pump?
The insulin pump is a programmable device that delivers insulin on a constant basis. So it's really a wonderful thing. It's about it's actually a little bit smaller than these meters.
Right.
And patients wear this on their belt. There's a small tube, a catheter, that gets inserted under the skin. The patients do this themselves. They change it every 2 or 3 days.
Oh.
And we can help program. We work with the patients and we help program the pump to tell the pump when to deliver insulin and how much to deliver.
God, that's great. That's
Yes.
wonderful. Then you could use that for type 1 and type 2.
That's correct.
Wow, and it's just a matter of you programming it to their individual needs.
Right, and we work together. The patients learn how to do this so that when they're eating a meal, they can program the pump to deliver insulin right then and there. And when they're not eating, they can just get a small, steady amount of insulin, the amount of insulin that we're all making, and just go about their life.
You know something, Dr. Briedart, I got to tell you that I learned a lot from you today, and I must state that here is the information that I got from you today. I got a message of hope and a message of optimism. If you follow the things that were discussed today, good medical evaluation, good diet, exercise, common sense, good, appropriate treatment, designed specifically for your needs, and with what exists today, there's no reason why an individual shouldn't be able to conquer this, not cure it, but learn how to live with this so that it doesn't get in the way of your life and that you could have a long, fruitful, happy, healthy life.
That's correct.
That's what I'm seeing from this.
Yes, there's no reason why patients can't check their blood sugar, have their blood sugars under control, and avoid most or all of the complications that we typically associate with diabetes. Just so easy to do nowadays.
It is. I mean, you've really made it very crystal clear, simple to understand. And there is absolutely no way in the world that individuals should be fearful of this and to understand that they can be helped. And to ignore doing this really is to create your own death warrant.
Yes, I mean, I would say that...
Can it kill you?
It can if you don't treat it, yes.
Or you can lose limbs.
Right, or eyesight. Right, or use of your kidneys, end up on dialysis. I mean, these are all avoidable problems. So
all because you just didn't do something about it.
Right.
We're out of time. Will you come back again sometime?
I would love to.
You're the best. Dr. Briedart, Rory, thank you so much for coming down. You're a busy guy, and I appreciate you taking the time to help me and to help my viewer understand exactly what this dreaded disease is all about and how it can be helped and conquered.
Thank you.
Thanks a lot. I hope that you got a lot out of it. I did. And the best compliment that I can give Dr. Briedart is that he taught me something today, and I hope that you got the same thing out of that. So until next time, we'll see you. And whatever you do, like Dr. Briedart, do it with passion. Otherwise, what's the use? See you again next time.
Thank you.